Welcome to our lecture material on grief after sudden death, obviously a really difficult topic that has affected many of us. So take care of yourself if this is hitting close to home. Here's what I'll be covering. First, just types of sudden death and some basic statistics. Then we'll review factors influencing the grief model, specifically for sudden death. Then we're going to again talk about manifestations of grief, more specifically for sudden death in these three instances: drug overdose, homicide, and suicide. And then we will go further into suicide, its prevalence, risk factors, and interventions, as well as some resources for mental health. Okay, so let's start with an overview of sudden death types and some relevant stats. So we can have sudden death due to diseases, like a heart attack or a stroke, natural disasters like fires or tsunamis, earthquakes, due to war, genocide, or terrorism. We can also have accidents, typically car accidents or drug overdose, homicide or suicide. And it's the latter three that we're going to be focusing on in this lecture: deaths due to overdose, homicide, and suicide. So when you review the leading causes of death by age group here, you can see that death by accident, whether that's car accident or drug overdose, is the number one for people who are less than 45 years old. And then for adolescents through kind of young adulthood, it's suicide, and then followed by homicide. Accidents continue to be high, whether it's drug overdose or car accidents, as well as suicide for middle and older adults. But it's just less likely to be the reason that you die that age. In fact, if you look at this data, suicide rates are highest for ages 55 to 64, but it's the 8th leading cause of death because there's other things, that are leading to people's death instead. Suicide, as you may have been hearing in the media, is trending up in most all age groups since 2010. It's highest for those over the age of 45, and we've seen a big increase for those in the age of 45 to 54 category. It's now near the top in this graph. And we also want to note the black line, which is the increase for ages 15 to 24, which is a pretty big jump in the last 15 to 20 years, even though lower compared to the other ages. This is data specifically from Colorado for drug overdose. You can see the highest rates by far are for prescription opioids, but also high amounts for meth and heroin that have been rising, with cocaine on the decline. Let's talk about some specific factors influencing grief in sudden death. So just a reminder of this model, which you've seen a few times, the factors influencing the grief model. We're going to focus on 3 out of the 4 quadrants as we move forward on the next few slides, everything except characteristics of the bereaved. So one of the characteristics associated with the deceased is the relationship to the deceased in sudden death situations. We know that people don't have time to say goodbye. That means that they're often left with unresolved issues, which is one reason why we are trying to not leave things unsaid, right? Conflict unaddressed, because we can tend to have regrets about that. And if this is someone dying at a younger age, which it often is in sudden death situations, then there's this sense that it's off time, that they've been robbed, that their life has been cut short. Actually, if you visit Grandview Cemetery here in Fort Collins at the end of Mountain Avenue, you'll find a couple of gravestones that are look like tree trunks that have been cut short, because of that, someone dying too young, life cut short. Okay, so Ken Doka delineated some characteristics of death events in the case of sudden death that are useful, and we can use this understanding to help acknowledge and normalize for people, why some sudden death situations are particularly challenging. So the first one is natural versus human-made. So generally, a human-made caused death is going to be harder than a naturally occurring death, whether that's death due to disease or natural disasters, because we are more likely to have a sense that a human perhaps made a mistake. If it's a natural death, we might be angry at God. If it's a human-caused death, then we're often more angry at the responsible persons, especially like, for example, in the case of medical error. In terms of degree of intentionality, how intentional was it that someone caused someone else to die? So obviously, first-degree homicide is the most intentional. But a step down or several steps down could be vehicular homicide due to driving under the influence. And then, at the other end might be you got into a car accident due to icy roads and it led to someone else's death, where that's not considered to be intentional at all. Generally, higher levels of intentionality are harder for us to cope with. The degree of preventability. So was it a heart attack and they've had warning signs and they should have been doing more to take care of their health? Was it homicide? It came out of the blue. However, it was someone's mistake, someone's bad decision that led to this. Medical error, if it can be preventable. And so whenever we have deaths that are more preventable, we do have a stronger obsession with the loss, a stronger sense of guilt and anger, more questions about kind of what ifs. In terms of the degree of suffering, do we believe they died instantaneously, or do we believe there was a question of suffering versus a clear indication of suffering? The more we think that there was suffering, then that can be difficult for us. We can be preoccupied with the amount of suffering that our loved ones might have experienced. And so what I used to tell people is it's okay to reprocess that suffering or use that suffering as a touchstone for your grief, as a way of kind of letting out the difficult feelings. But it's important to remember that even though you replay the possible scenario in your mind over and over, your loved one isn't suffering over and over as you replay it. That's done for them now. The scope, which is the number of people affected. When large numbers of people are affected, support could be limited, such as in the case of Hurricane Katrina, or it may be that support is more. Survivors and communities come together, and we have more of a sense of validation for our loss, such as in the case of 9/11. The degree of expectedness. So this is a loved one who died by suicide. Had they already attempted? Was there severe depression? If this was a loved one who had a heart attack, was this already something we were worried about because of health problems? Versus was it a total surprise? It's harder if it really comes out of the blue and totally unexpected. And then the last one I added, which is based on Pauline Boss's work and ambiguous loss, which you've learned about already, which is the degree of ambiguity. So when there is not a body, for example, due to an explosion or a plane crash, or we're not sure how they died, like in the case of 9/11, people didn't know how their loved one dies, or if there's unsolved details around a homicide, all of that can lead to more preoccupation and make it more challenging for people. And so you might consider what you've witnessed or experienced as characteristics of sudden death that have made it more challenging. One of the characteristics of the death event that influences grief is whether or not someone was able to view a body following the death and what state the body is in. And of course, when a body has been damaged, say due to a car accident or a gunshot wound, it is hard to figure out whether or not it's okay to view the body or how much of the body. And so it is a good idea to talk to funeral directors and see what they recommend. I think in the past people have been prevented from viewing the body following sudden death, but the downside is that family members might have a sense of unreality. They might not have the closure, or their imagination might be actually worse than reality. So as hard as it might be to view a body, on the other hand, once they see it, then they can allow themselves to grieve, what happened to the body, and perhaps move forward in a way that they weren't able to. However, at the same time, we know that we can't unsee images once we've seen them, and so we want to proceed with some caution. Oftentimes what funeral directors will do, they will cover the body, especially the more damaged parts of the body, in a sheet, but leave a hand or an arm out. And then they want to prepare people for kind of what to expect. So we're going to have a sheet covering her body. I'm going to have her hand out. You can certainly hold her hand. If you'd like to look at other parts of her body, especially parts that might be more damaged, let me know so that I can prepare you and perhaps pull back the sheet just in little portions rather than all at once. So you're giving people permission, you're giving them a sense of a control, but you're also trying to be thoughtful about what might be potentially difficult. Related to viewing bodies following sudden death is this protocol that was developed by parents of murdered children who wanted to view photographs from the crime scene. Again, with the idea that sometimes the not knowing is harder than the knowing. So the protocol that they developed, which I think is useful and could translate to other instances, just such as viewing the body in real life, is that if you're, for example, going to the police station, you bring a family member with you who can handle difficult things and is a strong support person for you. And then you ask the agency to put the photos that you could potentially review in a separate envelope in order of least offensive to worst offensive. So the easiest to look at, none of them are easy, of course, and with the most difficult to look at the end. And then the support person would start with the top photo, look at it. The other person, the griever cannot see it, so they would look at it, kind of allow their face to react to what they're seeing, express the pain, the shock, and then describe the photo to the family member. And then the family member would choose whether or not to view that photo. And then at any point they could stop or they could proceed. But that way you're going slowly, not kind of all at once, and being thoughtful about it. My mom had a client whose her teenage daughter had been killed in a car accident and her body had been damaged. And she struggled with not knowing, what her daughter had looked like at the end. And so she obtained the photos from the accident scene, but she didn't open the envelope. And she brought it to my mom, who kept it for her. And she just wanted to know that she had the option. I don't think she ever followed this protocol, but they were prepared to. Okay, so then the last category for factors influencing grief is societal factors that might come into play specifically with sudden death. So in sudden death situations, the media does get more involved, and the sensationalism could be hard, or if you're finding out details via a news reporter, that can be very challenging. At the same time, having media portray your loved one's death could be validating to the significance of it. Most of the time when a loved one dies, the media doesn't, it's not a big media headline, even though it feels like a huge headline in our personal lives. It can also, however, create challenges when media might get the details wrong or report kind of sensitive details. So, for example, I knew a woman whose son died, they believe by homicide, although it's an unsolved murder, but the newspaper initially reported suicide, and it always bothered her that her whole town, that the whole town thought that he died by suicide when he probably didn't. When law enforcement is involved, which is very common in sudden death situations, then they're doing their job, and that means that they're treating the situation as a crime scene. They might be interrogating people. This might feel really not conducive to if you've just experienced the sudden death of someone close to you. So the same woman whose son had been murdered, she talked about the challenges that the police officers wouldn't let them in the house. They wouldn't let her see the body when it was brought out on a gurney, and so there were challenges in that case. My father-in-law died of a heart attack at 71, and he was home alone in his bed, and because he didn't have any known heart issues and he wasn't on hospice or anything like that, it was treated like a crime scene. They didn't know if it was drug related, and so his friend had found him and notified his girlfriend, Norman's girlfriend, to come, and by the time she got there, they had it taped off and they wouldn't let her go in and say goodbye, which was pretty challenging. And then we're going to get more into, criminal justice systems. So seeking justice for example, a homicide. On the one hand, it's maybe good to have justice, but on the other hand, it's a long process, can really drag and delay grief, and you can continuously feel re-victimized throughout the process. And then again, we'll talk more about societal attitudes and specifically stigma. As we might expect, people experiencing the death of someone close to them suddenly really have an intense sense of shock and life disruption because they weren't expecting this. It can be really difficult to cognitively process it. They feel like they're kind of just mentally going over it again and again, or it has this sense of being unreal or surreal, or they're kind of retrospectively reconstructing all these events kind of related to the death. Struggling more with a sense of ability to cope with this, a sense of violation, loss of a confidence or security in the world, again, that lack of closure, unfinished business, and of course, more likely to have a longer and more complicated grieving process. So talking more about stigma, people who experience the death of someone due to suicide, homicide, or drug overdose, these are all stigmatized losses in which victims are usually viewed more negatively and subject to labels like careless or drugged or irresponsible. They're blamed somehow. And families of homicide and suicide victims are also stigmatized because it's believed that they should have been able to stop this. They are less likely to receive sympathy cards or verbal condolences, yet more likely to feel that others are talking about them. And research studies have found that people view suicide survivors more negatively than survivors of a natural death or an accident. They're viewed as less likable, more blameworthy, less psychologically healthy, and more able to have prevented it. So again, this is going to put us more at risk for disenfranchised grief, right? Our grief isn't as seen as valid. And of course, more of a risk for complicated grief, PTSD, and depression. The Megan Devine reading that you're doing has some nice information on why we do this, why we blame the deceased and or surviving loved ones. And Devine says that in the cases of sudden death, it creates fear in us that that could happen to us too, or someone we love. And we judge or blame as basically a way to get some distance, some control, some safety. And I think this might tie back to our conversation earlier in the semester about sympathy versus empathy, because sympathy also has that distancing effect. And so by judging or blaming, we are distancing ourselves. And I'm wondering how much you find yourself unconsciously doing this. I know I do. When I hear of a sudden death, I'll often think like, oh, okay, I'll be unconsciously thinking why this isn't going to happen to me because I'm not going to do those things. So if you watch the Susan Klebold TED Talk, which is really good, I hope you'll kind of think about what she offers as some insight into why people complete suicide. What understanding can you gain? And then, as you know, Susan Klebold, who was the mother of Dylan Klebold, one of the Columbine shooters, experienced a very stigmatized loss and disenfranchised grief over her son. How do you hear this in the talk? And if you were going to use your acknowledging skills, how could you acknowledge the disenfranchised grief that she has experienced? Let's revisit our manifestations of grief model and talk about the implications for sudden death. So in terms of manifestations of grief related to drug abuse and drug overdose, here's some specifically in the emotional category of manifestations, and these are based on a book written by a good family friend of mine, Marcia Wiggins, whose son Cameron died of a heroin overdose in his early 20s. And Marcia is also a marriage and family therapist and a professor in human development and family studies. So, and many of these emotional manifestations can be happening even before the loved one has died. So you can be experiencing shame of having an addicted loved one, that you're blameworthy somehow, that you should have done something differently, especially if you're the parent. Experiencing intense guilt for not being able to do enough to prevent it, to help. sense of failure, powerlessness or helplessness to stop the drug use, anger at the loved one before death or after death, for making decisions, that led to, addiction and death anxiety, particularly prior to the, prior to the death. And then this one is tricky. People following the death of a loved one due to drug overdose might feel some relief for now they don't have to worry anymore. They're not getting that phone call in the middle of the night all the time, worrying about getting that phone call. And then yet they can feel guilty for feeling relieved. And this is something that you could imagine is really hard to talk about. And so you could consider bringing it up in a condolence card, or if you knew someone, you could just say, you may not be feeling this at all, but I do know that other people in your situation sometimes feel a little bit relieved that they don't have to worry anymore about what's happening to them, and then feel guilty about that relief. And so if that is happening to you, I just hope that you know it's normal. For manifestations of grief associated with homicide, if we think about the emotional ones, more intense fear and vulnerability, loss of control, more intense anger and rage, more of a sense of shame, blame, guilt, like we've talked about, feeling powerless, feeling abandoned. In terms of intellectual manifestations, there can be that more intense cognitive dissonance or disbelief or denial, like, how could someone have done this on purpose, to my loved one? And then you might have murderous impulses, to the person who caused the death. And then you feel guilt, shame, like you're going crazy. And then you might kind of withdraw, get depressed, because it's really hard to talk about that or feel those feelings. You will probably be more preoccupied or obsessed with the events around the murder, preoccupied with the possibility of suffering, with the damage to the body, and perhaps a need to use a stronger word than died, such as, my daughter was killed or my daughter was murdered. In terms of behavioral or social manifestations, people will often withdraw from social support either due to stigma or just in general, and are more likely to show safety behaviors, checking door locks, following your child when they get on a bus to go on a field trip, driving behind to make sure everything's going to be okay. Pretty common. Okay, in terms of manifestations of grief specific to losing a loved one by suicide, emotionally, as we might imagine, more intense guilt or shame or survivor guilt that you're alive and they're not, anger, a sense of being rejected by the deceased, that they would leave you, or perhaps by others because of stigma. In the cacciatore reading, for example, Jim says that he thinks others must think of him as weak, for not being able to stop his sons from suicide. So that sense of shame or guilt. In terms of intellectual manifestations, we're going to be more preoccupied with their motives, why they did it. It might be something that's our thoughts are just, we can't control them. We're thinking about it, whether we want to or not. We might have more of a sense of just denial that this has really happened. In terms of behavioral or social, again, we might withdraw from social support due to the stigma. We are more likely to lie about the cause of the death, not say suicide or say that they died in some other way. And then because some religions consider suicide to be a sin, we might be more preoccupied with the afterlife and where our loved one is now. So in the cacciatore reading that you're doing, Jim really describes intense withdrawal, paralyzing anger, intrusive thinking, and Cacciatore worked with Jim to come up with some steps for dealing with moments of intense rage following the suicide of his son. And so you can see the steps here. And I'm wondering how much you do something like this when you're experiencing intense emotion. So recognizing, in this case, the anger or the rage as it's happening, taking a stance of curiosity. How did it emerge? What triggered it? What is it about in this case? Making ourselves take some slow, deep breaths. If we're in a social situation, walking away, before we, say something we regret, and then moving into some mindful or relaxation activities. Okay, let's talk more about a super difficult topic, suicide, which again I know is difficult for many of you who may have had a loved one attempt or die by suicide or may have attempted suicide yourself. So as we spend the remainder of the lecture material on this, I hope you'll pace yourself, take care of yourself. We're going to cover risk factors. We're going to cover treatments, including 72-hour holds. So just keep all of that in mind. So you may have learned this already, but people working in this area suggest that instead of using the words committed suicide, because committed is associated with crime, we use completed suicide or died by suicide. And some stats, local stats in terms of Colorado, we are in the nation's top 10. Other states that are also in this top 10 tend to be in our region, interestingly enough. Montana, Idaho, Wyoming, New Mexico, Utah, South Dakota, North Dakota, and then also Alaska. It's the second leading cause of death here in Colorado for ages 15 to 44, with the top one being car accidents. As you probably already know, men are much more likely, 4 times more likely to die by suicide than women, even though women attempt much more often than men, and that's because men are more likely to use more lethal means like guns or firearms, whereas women are more likely to use overdose. And in particular, it's middle-aged Caucasian men who have the highest rates. Middle-aged and older Caucasian men have the highest rates of suicide, and so this is something important for us to have on our radar. Okay, I think you probably know some of this information given our greater attention to mental health issues, but the majority of people who die by suicide have diagnosed or undiagnosed bipolar or depression, so a mood disorder, even though the majority of people with a mood disorder don't die by suicide, as you can see from the graph. What are the reasons for experiencing a mood disorder? We know genetics is a big piece, as well as difficult life experiences around trauma and loss. And then some of that happens in combination, remembering what you've learned about differential susceptibility and orchids and dandelions. Orchids who are genetically more susceptible and then experience difficult, especially difficult early experiences, will be more at risk for depression. And then of course there can be acute experiences around severe health issues or injuries. I think you're probably aware of these signs of depression, but they're worth just running through as we, assess ourselves and those around us. So generally to have be diagnosed, as you may know, with depressed mood, you have to have had this most every day, most all day for at least 2 weeks. So it's feeling sad most of the time, not feeling a lot of joy in things that would normally bring you pleasure, feeling more hopeless or helpless or worthless, and that you don't matter, feeling irritable, angry, or agitated. And this can be particularly for males who might be more likely to complain about problems at home or at work rather than talking about depressed feelings. You can experience changes in appetite, sleep, self-care, interest in sex, sexual desire, more fatigue, loss of energy, difficulty concentrating, and less interest in school, work, or hobbies, more withdrawal, more physical complaints or health issues, perhaps particularly for men, who aren't given as much permission to express difficult things, and of course turning to substances as a way to cope. So I think we all know, what to do, right, about depression or bipolar, whether that's seeking psychotherapy, medication, increasing our social support so we're not so isolated, getting better sleep, exercising, eating better, taking care of ourselves. Yet it's really hard. It's easier said than done and hard to do. And so I think oftentimes people are experiencing stigma, embarrassment, shame, or just, kind of denying it, not really acknowledging how hard things are for them. In this TED Talk, Kevin will give some insights into the experience of suicidality and how the stigma basically around depression essentially is more isolating, increases the risk of depression and suicidality. So these are the strongest risk factors for suicide, and I think it's so important to know these so that we can be kind of having them in our minds when we're talking to family or friends or in our professional roles about people who might be struggling or might be suicidal. So as we've talked about already, being male and Caucasian and older are the biggest risk factors. And then followed by depression and other mental health issues and substance use issues. And so oftentimes those happen together, mental health challenges and substance use issues. More than 90% of people who die by suicide have those two risk factors, a mental health issue and substance use issues. Next is firearms in the home, because 50% of completed suicides involve firearms. Veterans are 1.5 times higher, so important to know. If someone has attempted before or has engaged in self-harm like cutting, that's a risk factor. Cutting is, I believe, a risk factor for attempting, not for completion. Family history around mental health or substance use issues or suicide or violence or abuse. We have talked about, well, maybe you've learned about it elsewhere, just the social contagion, around suicide. So others close to you attempting or completing suicide or hearing about that, in your community, which is why we try not to get too public about suicides and certainly the methods. And then, of course, some sort of acute stressor or loss of a relationship, a job, financial difficulties, the death. And then, as we talk about in some other HDFS classes, youth who are transgender, gay, bisexual, more at risk for suicidality. And so we want to have these in mind. And when we're talking to someone who's suicidal, whether that's personally or professionally, obviously it depends on how well we know them and the relationship, but we're trying to find out, are they receiving mental health treatment? Are they taking their meds? Are they using substances to cope? Do they have firearms in the home? Do they have other kind of stressful things happening so that we can be basically assessing the risk? I remember receiving an email from a student who was just talking to me about how much she was struggling in class. And she said, I recently came out as bisexual. My family kicked me out. I've also been diagnosed with bipolar and I'm not on my meds right now, but I'm using weed to cope and it's making it hard for me to come to class. And I was just basically ticking off the risk factors, right? Bisexual, acute loss of family support, mental health diagnosis, not receiving medication, and now using substances. And, I got to like 5 risk factors, and so I had to take some action to make sure that she could be safe. She was living in a residence hall, and so I reached out to that director and asked them to do a check on her and, make sure that she was connected to resources. Okay, talking about suicide I know is stressful, and so sometimes just thinking about simple models for taking action, not that anything's simple, but might be useful. And so this is the VAR model, which you may have learned about, or something similar, which I think is useful, and you can watch this little video for some nice language on how to respond. So this idea that V is validate, and we might be saying things like, I'm really sorry that you're struggling, it's okay to not be okay. And then some sort of appreciation, which is the A, I'm so glad that you told me. It takes a lot of courage to let someone know that you're struggling. And then the R being refer. Have you thought about talking to someone? Could I go with you? Here's some things that I try, what might be resources. And then you can also see basically the things that are what not to say, which are basically minimizing or focusing on the bright side. So when I was a college student, I went through 100 hours of training to be a crisis phone counselor, and we spent a lot of time talking about how to respond to suicidal callers. And this was a model that has always stayed with me in responding to suicidal ideation. And this is this idea that even though it seems counterintuitive, rather than trying to talk them out of being suicidal, we want to start by focusing on the side of the person that wants to die. Because instead of talking them out of it, focusing on the bright side, because if you think about family systems, if we try to talk them out of it, they can often almost react by getting more entrenched in their desire to die or more alone in the sense that no one kind of understands how difficult it is. So we're not going to tell them that they're right in wanting to die, but we're trying to validate that part of them, that side of them that wants to die. And so we might be saying things like, everything is so hard right now. You don't see a way out of this. It feels so incredibly overwhelming. The only way you can imagine getting some relief is to kill yourself. Or right now, it feels like you'll put yourself out of misery and maybe help other people around you too. So you can hear that I'm not telling them that they're right, that their life isn't worth living. I'm just acknowledging what they're experiencing in terms of the side that wants to die. And, the theory goes that if you stay with the side that wants to die and let people really talk about that, they will start to actually give you a glimmer of the side that wants to live. They might say, but I know this would be awful for my mom. And so then you could begin to use parts language, or the sides of them language. There's a part of you that wants the pain to be over. There's another part that knows that this would be tremendously painful for your mom. Okay, so again, many of you have probably learned information like this in mental health first aid courses or how to respond to suicidality. But with grief specifically, it's not uncommon for people who are grieving to say, I just don't know how I'm going to live without him. I don't want to live without her. Part of me wishes I could die and be with her and avoid all of this pain. Those are called reunion fantasies. And so we want to actually acknowledge and normalize those. We're not saying it's okay to take your life, but we are acknowledging and normalizing that this is a common part of grief. And so I remember a student coming to my office hours and sharing that her brother had just died. And she made a comment maybe like that, and I normalized, it's really common for people who are grieving to feel like they just can't go on and that maybe a part of them wishes that they could die. I would go on to say it's not so normal to actually act on that, but it's normal to have that feeling. And for her, that was just so powerful to know that she was normal, and that she wasn't crazy, for having those thoughts. But of course, we still have to assess for suicidal ideation. So when someone says something like, if he breaks up with me, I don't think I can go on, you do have to ask more. And you'd be surprised how many people actually tell you yes, that they've thought about it. And so if you ask, would you consider killing yourself, taking your life, harming yourself, however you want to ask that. I know there's different opinions on it. Most of the time, the person's answer to your question will be something like, no, I'm just so upset, or it's just so painful. But if a person responds with something like, yes, I've thought about that, because I just can't imagine going on, then you need to know how serious they are. And so asking on a scale of 1 to 10, how much they're thinking about it, how many times a day. And then once you've established some degree of ideation, you want to get a sense of lethality. And so sometimes people are just thinking about it as a kind of a coping, a way to think about ending the pain, but there's not ever something that they would actually do. And so you can ask that same kind of scaling question about how likely you are to do it. And that gives you more information. And then if someone says yes, and they're higher on intention, then you want to know kind of what the plan is and how lethal it is, and whether or not they have access to it. So if it's a gun, do they already have the gun? If it's the pills, do they already have the pills? How quickly can they implement it? How likely are they to be successful in killing themselves? And so then we're deciding where to go from there. What it's important, obviously, is that we're never doing this alone. We're always bringing other people in. We're always consulting with others, whether it's personal or professional. We're trying to get them to sit with you while we contact some other people to talk about what's happening to them. Even while they're still with you, we can reach out and call them. If the person is in a highly lethal situation, they're home alone and they have a loaded gun, then we do have to take steps, to contact someone who's, trained to intervene. You've told me something very serious and I'm concerned about you. Would you be willing to sit with me while we call the crisis hotline together? Or would you be willing to call the crisis hotline and keep me on the other line, or, something like that. We shouldn't, if we're not professionals, get into the business of trying to establish personal contracts, suicide contracts. And also it's important to know if you're going through a breakup and the person that you're breaking up with is suicidal, you never want to go over to their house to kind of rescue them. or drive them to the hospital, just because, I mean, you can use your judgment, but so many times, especially in the case of males, suicidal males can also be homicidal, and that's where a lot of those, kind of double suicide homicide happen, in breakup situations. And of course, you can always be calling the police to transport them to the emergency room, or to check on them, and that's called a welfare check, and police can even track people down, in town when they're out and about. I do think that this is getting more challenging for police than it used to be, just because of the volume of suicidality. But again, prioritize your own safety. Don't put yourself in a dangerous situation. Try to get them hooked up with resources in the moment. Always involve others, so that you're not the only one who knows. Even though we like to be confidential, right, we've got to kind of insist that we get others involved. I think it's useful to know what the mental health evaluation process looks like in most communities, and you may have experienced this, or someone close to you may have. So most hospital emergency rooms have 24/7, 365 days a year mental health evaluations and referral. And so a person can drive themselves there. They can be driven by a family or a friend if that's safe, or we can call and request the police transfer them to the emergency department or the emergency room. They are evaluated there in terms of safety, whether or not they would be a danger to themselves or a danger to others, and then they'd typically be transferred to an inpatient facility if they are deemed to be a danger to themselves or others. In Fort Collins, that's a place like Mountain Crest. And they're held as called an M1 hold, also called a 2710, where someone can be held against their will for 72 hours for further evaluation. If they are deemed during that time to be a continued danger to self or others, then psychiatrists can initiate a short-term certification that can last longer, so that people are required to get treatment. Okay. In case this has been really distressing, I've listed, which would be understandable if it is, I've listed a mindfulness exercise that you might want to do, or you might have something else that you prefer. There are links here for suicide prevention hotlines, text lines, also the CSU Counseling Center and the CSU Center for Family and Couple Therapy. Please let me know if you'd like me to add some additional resources, or if you need additional resources. All right, you have finished a really difficult PowerPoint. This is a picture of a live oak tree in Florida that my dad took. It's an image that grounds me. I'd invite you to look at it, take a few deep breaths before you move on with the rest of your day. Notice what emotions you're feeling. Notice the tension in your body. Take some action to release the stress of this topic. Talk to someone about it, journal, play music, exercise. Yeah.